Alright, in this video we will be discussing about primary progressive aphasia, also known as PPA. Primary progressive aphasia is why it is primary. It is primary because the underlying condition in which this kind of aphasia develops, the first symptom of that underlying disorder is usually aphasia in itself, right? That is what it is called as primary. And why progressive? Because it is progressive. Why? Because the underlying disease is usually a neurodegenerative disease. Neurodegenerative. Neurodegenerative disease. Most of the time the underlying disease is neurodegenerative disease, and it is an aphasia. Aphasias caused by neurodegenerative diseases have an insidious onset and relentless progression, right? The neuropathology can be selective, not only for gray matter but even for specific layers of the gray matter and specific cell types, right? We have discussed these 2 points. The clinico-anatomic patterns are therefore different from other aphasias. Clinico-anatomic patterns, indeed these are different. Why they are different, we will be discussing them. See, whenever there is stroke, whenever there is a neoplasm, or whenever there is a trauma, there is involvement of usually Wernicke's areas or Broca's areas or the parietal lobe, and it will cause Wernicke's aphasia, Broca's aphasia or conduction aphasia. But primary progressive aphasia develops in case of neurodegenerative syndromes such as Alzheimer's disease and frontotemporal lobar dementias, right? So Alzheimer disease and frontotemporal lobar dementias, they will cause primary progressive aphasia, whereas stroke and trauma, they cause Wernicke's, Broca's or conduction or other types of aphasia. So we have to basically understand that the underlying condition for primary progressive aphasias are totally different. These are the neurodegenerative disorders, and neurodegenerative disorders have a predilection for certain cell types in certain particular areas of the brain, right? And these are insidious in onset and they are progressive, whereas stroke happens suddenly and aphasia happens suddenly. Neoplasm occurs and it compresses the uh, language network in a very short period of time, so these are also kind of sudden. Trauma is very sudden and aphasia, resulting aphasia is also so these conditions, they cause sudden aphasias, but neurodegenerative aphasias cause insidious and relentlessly progressive aphasias, and these progressive aphasias are known as primary progressive aphasias. So this is the basic introduction of primary progressive aphasia. In these cases, the aphasia is an ancillary component, right? It is the main component. It is the primary component of the overall syndrome. A diagnosis of primary progressive aphasia is justified only if the language disorder arises in relative isolation and becomes the primary concern that brings the patient to medical attention and remains the most salient deficit for 1 to 2 years. Okay, what this line is going to tell us is trying to tell us that although frontotemporal lobar dementia and Alzheimer's disease, they cause aphasia, but their main they, they involve other areas also. For example, Alzheimer disease will impact the episodic memory. Frontotemporal lobar dementia will impact the cognition, right? So these kind of these neurodegenerative disorders, they are associated with PPAs, right? They can cause PPAs, but will they always cause PPA? No, they will never cause. They may not cause. They may not always cause PPA, right? PPA, we will we will label the condition as PPA only if the primary symptom is aphasia and it remains there for 1 to 2 years, before which the other components of the of the major pathology they arrive, right? So this is uh, a language disorder that arises in relative isolation. It must be in a relative isolation, means other problems they will come, but they will come after a certain time period, that is 1 to 2 years. 1 से 2 साल के लिए कुछ और नहीं होना चाहिए, सिर्फ एफेजिया होना चाहिए. PPA can be caused by either FTLD or Alzheimer disease pathology, right? We have discussed it just now. Sometimes Creutzfeldt-Jakob disease (CJD) can also cause, but this aphasia will be very rapidly progressive because CJD causes aphasia. CJD itself causes death within 6 months to 1 year. So the aphasia developing in CJD will be very much rapid in progression. Then there are three basic types of aphasias. These are three main types of PPAs. The first type is agrammatic PPA, right? Agrammatic PPA is the first type. One second. Agrammatic PPA is the first type. The clinical features of agrammatic PPA are it is low in fluency, means fluency is lost. Patient is not fluent. Impaired grammar and intact word comprehension is very important here to understand. Let me highlight it. The word comprehension is intact. This is the point to be remembered. The word comprehension is intact. It most closely resembles Broca's aphasia or anterior transcortical aphasia. We must remember that Broca's is like anterior transcortical only, but right hemiparesis or dysarthria is not there and may have profound impairments of grammar. The grammar is mainly involved and there is no hemiparesis. Why? Because Broca's aphasia occurs in stroke and there is no stroke in PPA. So in agrammatic PPA, although it resembles Broca's, but it will not have any hemiparesis. It will not have any hemiparesis. What is the pathology? Gray matter atrophy occurs where left inferior frontal gyrus, left inferior frontal gyrus, where Broca's area is located. Left this is the frontal lobe, superior, middle and inferior. Here it is the Broca's. Etiology, and where the Broca's is located at the same time, at the same place, there will be pathology of agrammatic PPA. Etiology is frontotemporal and Alzheimer disease. We have to remember this. Now second type is the semantic PPA. It is the second type. What are the clinical features of semantic PPA? Preserved fluency and syntax. Okay, fluency is preserved. Patient is fluent. Preserved. Poor single word comprehension is lost. Profound two-way naming impairments. Okay. See, the comprehension is lost. This is the major, difference between semantic and what we just discussed, agrammatic. Agrammatic में the grammar will be lost, and in semantic comprehension, if comprehension is lost, what do you think will be the pathology? The pathology will be uh, left anterior temporal lobe. It is near Wernicke's area. That is why this aphasia it resembles Wernicke's. though the pathology is not at the Wernicke's area, but it is near the Wernicke's area, means and left anterior temporal lobe. Though though it was previously understood that the Wernicke's area is responsible for comprehension, but as we have seen in semantic PPA that left anterior temporal lobe damage can also lead to comprehension loss. So comprehension is controlled by different areas of the language network. One of those language network is left anterior temporal lobe also. We must not forget this. Wernicke's area is still there, but at the same time another area left anterior temporal lobe is also responsible for comprehension. So this is basically a new thing to understand. The neuropathology is frequently an FTLD, right? And the protein which is deposited is TDP43. They say this kind of aphasia is not seen with CVS. It is not pathology. It differs from Wernicke's aphasia or posterior transcortical aphasia because speech is usually informative and repetition is intact. You know that repetition is intact. But repetition is gone in Wernicke's. Here repetition is intact. So this is all you need to learn by heart, because everything cannot be explained with the concepts. Some things you have to always remember. That is a problem, but that is how it is. There are different features of different aphasias. They are similar to the other aphasias in some sense. At the same time they are different from other aphasias in some other aspects. So it is all about remembering them. And what is the way to remember? The way to remember is to read them again and again. So you must go to the Harrisons, or you can watch this video again and again to make the things more and more permanent. Third type of PPA is logopenic PPA. Logopenic PPA. Clinical features is syntax is preserved, comprehension is preserved, but the patient stops for finding the words. The patient forgets the words. Anomia, circumlocutions, and simplifications. Repetition is usually impaired. Pathology. Peak atrophy sites are located in the temporoparietal junction and posterior temporal lobe, partially overlapping with the traditional location of Wernicke's area, right? The lesion in here is near the Wernicke's area. Etiology: Alzheimer disease, FTLD. Same. Now we have read three types of primary progressive aphasias. The third one is logopenic. By logopenic, the main complaint is the word finding pauses. The patient is not able to find the words. The patient forgets the words, and repetition is impaired. Comprehension is intact. Right. Etiology is again AD and FTLD. In addition to these three types, there is another fourth type. Fourth type is the mixed type of PPA, where grammar fluency and word comprehension are jointly impaired. Are jointly impaired. So a mixed type is the fourth type. So we have discussed the three main types of primary progressive aphasias. We have just read a few things about the primary progressive aphasias. That is all about PPS. I will be coming up in the next video with some other kind of aphasia, maybe anomic aphasia or apraxia. We will see you in the next video. Thank you so much for your patient listening.